Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Welcome to a new lecture of Spin Academics. I'm Dr. Jordi Roldan from Palma, Spain, and I'm going to talk about phacomatosis. No relevant disclosure, and that's the main scheme of the talk. And first, I want to mention the bibliography that I used to prepare the lecture. The recent book of the group of Wiesmann, Fetal Neonatal and Pediatric Neuroradiology from 2023. It's very interesting and very updated, and a classical paper from Smirniotopoulos from 2014, focused on neuroimaging of neurocutaneous disease. So the main scheme is, and I want to show you, is first I will talk about the concept of neurocutaneous syndrome. After that, we mention the big five, the most important but most relevant phacomatosis. Third term, the new concepts are related with the ways that are implied in this type of pathologies, just briefly, because it's not the most important thing of this lecture as radiologists, but we have to know. And then the imaging essence, that means the most relevant neuroimaging findings. So the concept of phacomatosis has evolved over the time. The term comes from, was coined by a Dutch ophthalmologist, Jan van der Hoop, who saw patients with NF1 and tuberous sclerosis complex with eyes anomalies, and he called them phacomata, which means lentil spot, lens shapes, or mother spot. Then the term evolved over the years, mainly in the 30s, to neurocutaneous syndrome, to congenital neuroectodermal dysplasias, and in the late 80s by a Spanish doctor, Manuel Rodriguez Gomez, used the term hamartomas. Anyway, even nowadays it's difficult to find a common definition of these etiologies, but we can say that it's an heterogeneous group of neurodevelopmental disorders affecting predominantly, but not exclusively, the ectoderm. Couldn't be autosomal dominant, recessive, or mosaicism. We are not going to go into detail about the double hit and this type of concept because of questions of time, but just mention if you are curious to deep in these terms. And the neuroectoderm means that the target organs are the skin, the eye, some parts of the eye, and the central and peripheral nervous system. Remember that it's not exclusive of ectoderm. That is, at the beginning was the people think that it was only ectoderm, but we know that it's not only ectoderm that is affected. Are the three main layers of the embryo: mesoderm structures, mainly blood vessels, bone and cartilage, and also endoderm, which is very representative of the gastrointestinal tract. And the relevant and the common characteristic of these neurocutaneous syndromes, and that's an opinion, it's not, it's in order to find easy to understand this very heterogeneous group, the common thing is the growth. That means tumors and malformations in any of these parts that I mentioned before. So which are the main types, or I call it the big five: NF1, NF2, tuberous sclerosis complex, Sturge-Weber syndrome, von Hippel-Lindau, and many others. And many others means a lot of a bunch and a lot of many others. I put in red the examples that I will show you later on, but there's more and more syndromes that you can consult in bibliography. I put this I will show you a faces cases, a blue rubber blood nevus, very rare entity, macular syndrome, and continentia pigmenti. These ones are vascular phacomatosis, these one are melanophacomatosis, and these one are other because it's difficult to group in some characteristic approach. And I will show you an hereditary ataxia telangiectasia and a basal cell nevus syndrome, but are, of course, many others. I put this slide to just relativize some terms that are not really, but that you have to think in, you have to think more not as a credo or a thing that is static, because all these entities are evolving. So I choose this quote from Jorge Luis Borges, an excellent Argentinian writer, that said, "It is clear that there is no classification of the universe that is not arbitrary and full of conjectures. The reason for this is very simple. We do not know what kind of thing the universe is, and that means that classifications are classifications, and they evolve, they change. They are not the God's word. If you want. So phacomatosis have things in common with other groups of entities, of recently and new entities, which are grouped, for example, in cancer predisposition syndromes. You would find also NF1, NF2, tuberous sclerosis, and von Hippel-Lindau in these cancer predisposition syndromes, as many others that are not phacomatosis. And also new terms, or relatively new terms, rasopathies and entorpathies, that are related with pathway affected. And you will find here NF1 and tuberous sclerosis complex, for example, and different classifications, but also you can find here in phacomatosis. So at the end, there's a mix of groups that share some characteristics. So at the end, phacomatosis, because are complex syndromes, now you will find also these entities in other classifications, especially cancer predisposition or using the molecular pathways. And that's the slide that the title is the ways, because that's the pathways that we all know that are very difficult for us, but it's very interesting just from the point of view of radiologists. At least you have to know that are involved in behind all these type of syndromes. The most famous are the RAS family, which is an oncogene family, and NF1 is involved. And that means that if it doesn't work, this RAS family, just for mutations in the NF1 neurofibrine, the thing is that there's a favor in producing tumors. And the other one is the mTOR, which is implied in many pathologies. But in our topic is related with tuberous sclerosis, which are the two complex affected, TSC1 and TS2. And if it doesn't work, that means that mTOR, which is a master of a regulator of cell metabolism and a promoter of cell proliferation, if it doesn't work, you will find tumors and in the brain cortical malformation, which at the end is the main findings of tuberous sclerosis. So that's the important thing to know. This mess of signaling pathway, but you have to recognize at least, and you have to know that behind these neurocutaneous syndromes there are complex pathways. And the other hand, why is important that? Because some new drugs are trying to correct these anomalies. For example, everolimus in tuberous sclerosis complex, which is acting in the mTOR way. So we are just mentioned this brief introduction to this white area, and now we are talking to the neuroimaging, the most relevant neuroimaging findings. So we start with NF1, which you all know probably because of the medicine career you study this, but I will focus on neuroimaging alterations. So NF1 is an autosomal dominant, but 50% are new mutations. The gene that is behind this is located in chromosome 17, and the result is the neurofurin, which is inactivated. And as I said before, RAS is not is malfunction, so at the end this protein responsible for tumor suppression doesn't work well, so you have a predisposition syndrome for tumors. And in the central nervous system, of course, would be gliomas. But which is the main characteristic of NF1 in the brain are these type of lesions. Maybe you will find in the literature UBOS or PHASE, which are called focal areas of signal intensity, that's PHASE, or unidentified bright objects, that is called UBO. Personally, I don't like this type of names because sometimes just are only confusing. I prefer talking about non-enhancing T2 hyperintense lesions, and where are located mainly? Where they're present in almost, I could say, almost all the children that have NF1, almost all have non-enhancing T2 hyperintense lesion. The characteristic sites are globus pallidus, thalami, cerebral peduncles, and cerebellar peduncles, and white matter of the cerebellum, and also in the midbrain. And there is another which is not so famous like the other, but it's the hippocampus. In the hippocampus, there's also an T2 hyperintense signal, and that's also this type of lesion related with NF1. Usually, they don't have mass effect and no enhancement, and the tendency is that to gone by adulthood. That means that resolve with time, and it's not necessary to worry too much when these type of lesions are located in the typical locations. The other typical lesion finding in NF1 are the optic pathway gliomas, which I have 4 examples here. This lesion, well defined, it could affect the chiasma or only one optic nerve. The best sequences are T2 and steer or some fat satin coronal to see the alterations in the optic pathway. If you are doing a follow-up, you can think if it's a need, if you need to put gadolinium to follow up. Personally, if there's an NF1 which is diagnosed and you know all the findings, maybe you can be more conservative and don't use in every exploration gadolinium. But that's an opinion. And you have to do the differential with this hamartomatose type of lesions in the third ventricle, which you can see also in NF1, and they're not gliomas. More typical lesions of NF1, this type of plexiform neurofibromas, which has a lobular and infiltration soft tissue appearance, could affect one side, 2 sides, or could be very, very, very large, as is in this case, both sides of the spine, and affecting almost all the spinal nerves of the cervical spine. And they are usually associated with when they are huge and are big and are affecting the orbits, are very, very related with sphenoid wing defects. So there's one plexiform neurofibroma. There's another one, also cervical, which you can follow the limits of the lesion, and also here in the occipital zone. Here you can see this is the escaloping of the posterior body. It's very typical of NF1. That's a dural ectasia. That's a T2 and sagittal T2 of the spine. And here you can see another huge plexiform neurofibroma, which has this target appearance here, very, very typical of plexiform neurofibromas that target a sign in this type of nervous tumors. Of course, NF1 can have vascular anomalies from vascular ectasia here, which you can see that this portion of the internal carotid artery is very, you see at least three times. And this type of ectasias of the main intercranial vessels are very typical of vascular dysplasias, which is in the case of NF1 the thing that is behind these type of findings. You can also see aneurysm, as in this case in internal carotid artery in 3D or MIP reconstruction here, and in P1 also you can see this type of aneurysm in 3D and MIP reconstructions. There's also a vascular dysplasia, which could reflect the moya-moya effect, which is this extreme occlusion of the distal internal carotid artery and the proliferation of lenticulostriate collaterals, which form the moya-moya arteriopathy or moya-moya complex, very typical in NF1. You see here this typical hyperintense lesions in basal nuclei and also and another thing that is not so it's not so popular is the increase of white matter volume in NF1. Here you can see this big corpus callosum, and also the columns of the fornix are increased. And here bone dysplasias are very typical, which this body sphenoid has lost the normal form of the sphenoid bone. So dysplasia of the sphenoid dysplasia the sphenoid wing dysplasia is very typical of NF1 and very significant of this entity. So we next slide about NF2. NF2 is also autosomal dominant, and 50% are new mutations. The typical characteristic are multiple extraxial tumors. As in this case, you can see these schwannomas of the vestibular nerve bilateral. This very huge, and this appearance of like a cone that infiltrates or enter the internal auditory canal and located in the pontocerebellous angle, and in this case are bilateral, left side bigger than right side, but here it is another neurofibroma schwannoma of the vestibular nerve. 5 nerve and hypoglossal are also common in NF2. And the important thing of NF2 is that you have to rule out another tumors, for example, in this case, a meningioma and also an ependymoma, and it conforms the MISMI acronym, which means multiple inherited schwannomas, meningiomas, and ependymomas. And I say neurofibroma, but the correct is schwannomas in NF2. Neurofibromas are related with NF1. So this type of tumors are schwannomas. And the other thing is, if you find a schwannoma in a young adult, you have to rule out NF2 and seek for other stigmata. Another case of NF2 courtesy of Dr. Villes from Hospital del Mar. And the same, you can see here more tiny lesions of the vestibular nerves, a small meningioma, and this condition, these calcifications of the cerebral hemispheres, which is called meningoangiomatosis, and are cortical subcortical heterogeneous lesions with variable enhancement, calcified overlying leptomeningeals, and that's the term of meningoangiomatosis, very typical of NF2. And you can see here also an ependymoma on the distal of the dorsal lumbar spinal cord, which is very typical also of NF2. It's very important to the differential diagnosis. For example, this lesion seems an extra-axial lesion, and you can say, okay, maybe it's a meningioma, but 8 years, it's not the typical age, and also it's not the typical location in the cerebellum. And also the signal of diffusion, which is very cellular, it's not typical, and that's the SHH medulloblastoma, very characteristic. And also you have to do the differential in this type of tumors. Don't rush and say it's okay, it's very easy. It's a schwannoma of the vestibular nerve, but here you can see that there's no expansion of the auditory internal canal. That means that it's located here and it's not extending through the auditory internal canal. That means that it's less probably that it's a schwannoma. And in this case, you have to remember this type of tumor, Wnt medulloblastoma, and think that you have to complete the examination with a spinal cord MRI. Next, one of the big five, the complex tuberosclerosis or tuberosclerosis, mutations in TSC1 and TSC2, autosomal dominant, and the malfunction of this, as I mentioned before, of these suppressor genes that lead to tumors and malformation. The thing is, these are one of the main characteristics, the subependymal nodules you can see also in fetal life, this type of hypointense tumors lining the ependymal, bilateral, irregular, very, very typical of tuberosclerosis. Could calcify over time, and between 30 and 80% could enhance. And you will find elongating nodules in location of fetal germinal matrix, which is this characteristic. Here, hypointensity 2 and hyperintensity 1. And here, this is peripheral. There is also a rhabdomyoma, a mass, a cardiac mass, which was a rhabdomyoma. We have to mention that the signal of this, not the subependymal nodules, but radial migration lines change and evolves over time because of the different myelination during the neonatal period and in years after. So here you can see these ependymal nodules, these radiation migration lines, and these radiation migration lines are usually or the way or the path to find this type of more cortical lesions, which are, well, first, differential of periependymal nodules. In this case, the signal is similar to the cortex. That means that it's not anomalous tissue. These are heterotopias, and this is the FLNA, periventricular nodular heterotopias, which also has cardiovascular anomalies, in this case a pulmonary dilation. So be careful with the ependymal nodules and the differential diagnosis. Here, the cerebral cortical tubers, very typical hyper intense lesions, cortical subcortical lesions, expanding the gyria, very typical of cortical tubers. Could have calcifications and usually don't enhance. That's an interesting case because it was the presentation was seizures and we saw these peripheral calcifications. We didn't know what's where we did a wide differential, but at the end the EMR will answer the uh, the main diagnosis, and is the appearance of cortical tumors. That's a tuber sclerosis presentation. Another lesions of tuber sclerosis, the cerebellar tumors. Passing time, this type of lesions could calcify and are very similar to meningoengyomatosis of NF2. And remember, this type of tumors with a peripheral calcifications in the floor of the third ventricle, which are very, very typical of SIGA, subependymal giant cell astrocytomas, which are grade 1 of the flu. And if there's an implication of initiating the therapy of everolimus, sirolimus to diminish the size of the tumor. In this case, was treated surgically because it's too big to be treated only by drugs. The other main issue is the Sturge-Weber syndrome, which is an encephalocraniocutaneous leptomeningeal disease. The main characteristic is the facial port wine stain, which is located in dermatomal way, and it depends on the location. The risk of developing a Sturge-Weber syndrome is higher. You see here this scheme, which is the wider, the higher probability that you would have also a Sturge-Weber syndrome. There are 3 types depending on the affecting ophthalmological or the probabilities of having ophthalmological complications, and if there's a facial capillary malformation affecting brain, eye, or so 3 types. And which are the main characteristics? That's the leptomeningeal angiomatosis. Here is almost all the left hemisphere with tortuous leptomeningeal vasculature, enhancement, this ipsilateral enlarged choroid plexus. These type of lesions are in the same site of the port stain wine. So are unilateral, and if there's very severe, you will find this calcified vessel because this chronic venous congestion. Remember that you could also find hypertrophy of the skull of the same area because the atrophy of the parenchyma. There's another example of the same focal. This is more focal than the other, focal calcification of the leptomeningeal angiomatosis, and here you could see also that there's an hypertrophic vessels in the skull with an hypertrophic calvaria in the same area and a loss of volume of the same hemisphere. Of course, calcifications are in ASLR hypoperfused areas. A relatively new finding described in 5 years ago by the group of Genova. There's at the same place, at the same site of the angiomatous leptomeningeal angiomatosis, you will find an asymmetry of the cavernous sinus, much bigger than the opposite. That means chronic venous congestion. So cavernous sinus enlargement is another finding related to Sturge-Weber syndrome. And of course, the choroidal scleral angiomatosis of the same site, very typical of Sturge-Weber syndrome. Finally, the fifth big type is the von Hippel-Lindau syndrome, an autosomal dominant gene implied in chromosome 3, And the most common feature are hemangioblastomas. And hemangioblastomas has a very characteristic issue is that it seems like a pilocytic astrocytoma, and that's for example, that's you could say, okay, that's could be a pilocytic astrocytoma. But remember two things. There usually has these patients have more than one lesion. Could also have one lesion, but in this case, more lesions, more than that. And also remember this one. This characteristic is very, very important. These flow voids that are, for example, located also in the cervical spinal cord, and this type of flow voids are very, very characteristic of hemangioblastoma. So keep in mind that it's not the same like astrocytoma, like a pilocytic astrocytoma. That's an interesting difference between the two of them. And this type of patients could also develop an endolymphatic sac tumor, which is a very rare tumor, and also has many other characteristics in other places of the economy of the body, as kidney, pancreas, adrenal, and cystoadenomas. So others, the rare ones, and I started with Faces syndrome, which the etiology is unknown, occurs sporadically, and is it's very, very typical in females. So almost all the cases we see are females. There are major criteria which define the acronym: posterior fossa anomalies, Dandy Walker malformation, arachnoid cyst, hemangiomas, arterial, intracranial, extracranial arterial tortuosities, cardiovascular, coarctation of the aorta, eye microphthalmia, optic nerve hypoplasia, or and if the face or faces, if there is an S, there is a supraumbilical raphe and sternal cleft defect. And also there are minor criteria, which mainly are ventral septal defects, fetal arteries different from trigeminal artery, which is not so rare, and also pituitary gland and thyroid anomalies. In this case, you can see that there's no left internal carotid artery, completely absent. And look at this angiomatous aspect of this intercranial vessel that you can. It's very difficult to define where is the the cerebral anterior, the anterior cerebral artery, the posterior, or the middle cerebral artery. Very, very difficult. And you have here like dilations, aneurysms, and this type of, or even moya phenomenons around the cerebral medial artery. That's very, very characteristic of Faces syndrome. And this is the repercussion. When you have problems with the vasculature, you have more probabilities to develop a high ischemic lesions in the white matter. Here you see this. Look at this in front to the pons, because these large vessels. There's a definitely diagnosis of Faces if there are these criteria, and a possible Faces when there's this definition. If you want to check these characteristics, you would check, because there's a difference of Faces and a possible Faces, because sometimes there's a lack of criteria. There's not always presented this type of this 6 criteria in Faces syndrome, and we call it a possible face. And interesting to say that the difference between capillary malformation and infantile facial hemangioma, because sometimes clinically you could have the difficulty to say, okay, is it structural or is it Faces? So I did that table to resume this. You could add it in the differential. So if it's present at birth, is structural and it's a capillary malformation, and if it follows a dermatomal distribution, also the probabilities of Sturge-Weber syndrome are higher. On the other side, faces and infantile angiomas has a rapid growth and a rapid progression. Sturge-Weber capillary malformation doesn't change over time and these are treated, and they are not present at birth. So if you want to add this to your, even if there's not neuroimaging characteristics, maybe you can add in your diagnosis or your clinical information. There's another case of faces syndrome, not as extensive and severe like the other, but you can also see these different patterns of dilations of one side and the other side, one more developed, static and dilated, and here these anomalies of the posterior fossa, like in defoliation, that this case doesn't follow the folia. They are not parallel to the calvaria. Did you have this type of foliation perpendicular to the others, and these middle paramedial hemispheres are dysmorphic related to the other. And here you can see also a dysplastic frontal cortex with alterations at this gyric cortex, different from the other orientations of the rest of the cortex. Blue rubber bleb nevus, another rare entity, and mainly characteristic is the presence of large venous malformations here in the inferior extremities, also in the gastrointestinal tract, in the neck, and here these huge venous malformations that produce an scalloping of the skull, even a lytic lesion. Here you can see here because the pressure and the growth of the vascular malformations. The ataxia telangiectasia, an autosomal recessive disorder, which the main characteristic is the cerebellar atrophy. So keep in mind this entity when you see a cerebral atrophy that are very, very extensive. McCune-Albright, another rare entity which the characteristics are cafeole spots like NF1, precocious puberty, and polyostotic fibrous dysplasia, as in this case you see this thickened calvaria in the left side, also in the right side. And if you do a CT here, you can see the sphenoid, the very large ground glass, also the temporal bone, and the escamous part, also the petrous part, and also the contralateral, very typical of McCune-Albright syndrome. Another one, incontinentia pigmenti, X-linked mutation in the NEMO gene. The characteristics are this hypodontia, to see here, hypodontia here, microphthalmia in the right side, cyst, structural cyst, and you see here the result of chronic infarcts here and some of insulin and loss of gyration, and also chronic infarcts in the left hemisphere and hypoplastic corpus callosum. Finally, the basal cell nevus syndrome, aka the Korlin-Kold syndrome, and the relevant finding, especially is this type of cyst, odontogenic cysts that are very conspicuous here, the maxillar and the mandibular parts, which are keratocystic odontogenic tumors. Used to be unilocular, and here you can, the correlation with the CT, you would find this type of cyst in both maxillar and mandibular parts. So which are the take-home messages? If you try to surf in the waves without falling off your board, remember that neuroimaging is the hub of the neurocutaneous syndromes. Start with the big five and don't give up. You have to study the main characteristic. Remember that behind mountains are more mountains. That means that you have to think of the other associations, And please don't stop when you find one anomaly, because there are more anomalies that you have to find. That's all. And thank you for your attention. And I hope you will find this interesting, not so uh, large in terms of duration of the talk. Thank you very much.